medical oncologist from Jaslok Hospital, Mumbai, and he will be speaking on KEYNOTE-024 5-year OS update, first line pembro versus platinum-based chemo in patients with metastatic mNSCLC and PD-L1 TPS more than or equal to 50%, and also guidelines to manage immune-related adverse events toxicities. I also request Maheboob to give his expertise during the panel session also, as requested by the moderator of our panel. So later on also, you will join the panelist also as an expert panelist. So over to Maheboob.
Good evening and thank you, Bharat. Thank you for inviting me over here. And nice to see Chirag also. Yeah, and thank you, MSD, also for inviting all of us over here. So let me start sharing the slides. Can you see my slides?
Yes.
Yeah. So what I would be discussing about the leveraging 5-year survival, as just now the Rahul has shown the 4-year data of the NEO-EP combination. I will be presenting the data of the pembrolizumab, which is a 5-year survival OS data. We all know that the lung cancer is one of the highest incidence in India and 4th highest cause of death because of the malignancies. And Chirag and Bharat, if you remember, we used to have our meetings and discussion regarding only the combination of various chemotherapy options, like with cisplatin or carboplatin. We used to combine either with paclitaxel or docetaxel or gemcitabine, and we used to have discussions regarding this, which is better combination. And then later on, the pemetrexed came in 2008, and we know that majority of our patients didn't survive beyond 2 years. Then there was an addition of bevacizumab, typically for the patients from the COP study, where the chemotherapy was combined with the bevacizumab, and it did show some benefit in survival. But the things changed when the Keytruda, the immunotherapy, came in 2017, and from there onwards, there has been a lot of change happening into the overall survival of the patients of the lung cancers. We all know that 50% of our lung cancer is molecularly driven by some driver mutations like EGFR, ALK, and so many others. Those patients who do not have, but have a high expression of the PD-L1 or the PD-L1. So for such patients, the immunotherapy is having an option. So I did remember one trial which I was going to do for GVHD, for bone marrow transplant, somewhere around 20 years back. And that time they mentioned that PD-L1 is the marker of the, NCI has rated PD-L1 as a #1 marker. That was the first time I read about PD-L1, and I didn't know its implication, that it will come over a period of time in lung cancer in such a big way. So why should we choose the PD-L1 as a marker? And that is based on the training data and validation data groups based on the study of KEYNOTE-001. And in KEYNOTE-001, the PD-L1 expression evaluation was done based on the TPS score of more than or equal to 50, while the further subsequent randomized trials, they took the TPS score 1 and above 50. So we know that now less than 1 to 49 and 50 above. That's how we take into the account while deciding the treatment. And as you can see, the prospective validation of TPS score and the clinical benefit is definitely seen even in the KEYNOTE-1. I'm not going to present this data, but there is this data is also showing that those patients who have not been treated with any therapy and they are chemotherapy or any treatment naive, they have very high chance of survival. That means almost 29% at the end of the five years when the TPS score is more than 50%. While if they have been previously treated, then somewhere around 25% is the 5-year survival rate for the patients who did receive some treatment. So NCCI guidelines suggest that whether the patient is having an adenocarcinoma or squamous cell carcinoma, you should do the basic EGFR, ALK, ROS, BRAF, MET. Along with that, the PD-L1 testing for all the patients, and that's an important parameter for all that. So in short, I will be presenting about the two phase 3 trials who have a 5 years overall survival data. The first is KEYNOTE-021, which is a first-line metastatic non-small cell lung cancer, and where the TPS score was more than equal to 50%, and the KEYNOTE-010 is the second-line metastatic non-small cell lung cancer. And obviously, we know that all the EGFR ALK negative patients were included, so no driver mutation was found in such patients. So let's look at the KEYNOTE-024 OS data, which was presented here in the last year ESMO, which happened virtually. And what they did in the KEYNOTE trial, that all the patients with stage 4 non-small cell lung cancer were included with TPS score more than equal to 50, good performance status, they should not have any EGFR ALK mutations. Treated brain metastatic patients were included, but the patients who had an autoimmune disease or requiring an active systemic therapy were not included, and they were randomized to receive single agent pembrolizumab 200 milligram every 3 weekly for 2 years, as compared, and it was compared with the platinum doublet chemotherapy for 4 to 6 cycles. And those patients who failed on the or progressed after chemotherapy, they crossed over to the pembrolizumab arm. And those patients who have a pembrolizumab, who finished 2 years, and if suppose they progress, they did continue further pembrolizumab for 1 year. So somewhere around 300 patients were included, and 150 in each arm. If you look into the chemotherapy side, 150 were treated, and out of that 150, 29 only could complete the treatment. 121 discontinued, mostly because of the progression of the disease. That was almost 77. There were a lot of AEs and 9 deaths. And out of this 121 which discontinued, 83 crossed over to the pembrolizumab arm, and they were treated with the pembrolizumab or afterwards. So that also has an impact on the overall survival. While in the other arm of where the pembrolizumab monotherapy was given, in 154 patients, 34 completed and 120 discontinued, and mostly because of the progressive disease, that is 72. If you compare numerically 72 figure is little better compared to 77 from the chemotherapy side. And those patients who received subsequent therapy including 12 patients who received second course of the pembrolizumab arm. I won't go into much detail, but you can see over here the patients with histology somewhere around 20% in both the arms, and treated brain mets were somewhere around 10% in the pembro arm versus 6% in the chemotherapy arm. And all patients were chemotherapy naive. They would have received neoadjuvant or adjuvant therapy, but no treatment for the metastatic disease. And you can see the 5-year overall survival rate. At the end of the 3 years, it was 42 versus 24. At the end of 48 months, it was 35 versus 20. And at the end of the 60 months, that is 5 years, you have 31% patients alive as compared to 16% those patients who were on the control arm. And if you see the Rahul's data of 4 years of 29%, practically it's close to that figure that what we had seen with the combination of Nivo and EP when you don't give chemotherapy to such patients. PFS, though you know that the PFS figure doesn't look as good as OS data. You have a 7.7 month versus 5.5 months, because we know that immunotherapy immediate in the first 6 months to 12 months, the chemotherapy already scores over the immunotherapy, but immunotherapy survival is seen over a period of time. And those patients who have without progression, almost 22.8% patients at the end of the 3 years. So that means that the patients who are on immunotherapy are doing much better as compared to patients receiving only chemotherapy. There were almost 4% complete responses. Partial response was 40%, and stable disease was in 24%. So the duration of response, if you see, is almost 30 months as compared to 6.3 months with the chemotherapy. This is also statistically significant. The most important, another Rahul also did show the data that those patients who have completed the treatment of 2 years and they did very well, almost 81% of the patients had a 3-year OS benefit from the completion of pembrolizumab. That means 5 years from the randomization. So almost such patients had, though the number was small, almost their survival was excellent. And there, I think survival was somewhere around 74-75%. Here it is around 81% of patients. So they had only somewhere around 39%. 39 patients had received this kind of thing. So adverse events are also an important one. And if you see the pembrolizumab had a grade 3, grade 4 toxicities, and serious adverse events also were common in the immunotherapy arm, and that also almost in 13% of the patients led to the discontinuation and 1% related to death. So you have to have a very vigilant eye on finding what the patients are having in adverse events. So one should always look for the adverse events, and I'm going to talk about the how to manage the adverse events in the next topic. So in summary, we can say that KEYNOTE-024 is a landmark trial which shows that the 5-year survival rate for such patients is somewhere around 31.9%, and the median duration response of almost 30 months in the patients who received the pembrolizumab arm. Patients who completed the 2 years of pembrolizumab have experienced a very long OS, and this is very important from the patient's point of view because they have never received any chemotherapy in their lifetime. Yes, side effects are important. You have to be very careful, and there are discontinuation of the immunotherapy agents because of the toxicities, and one should be also looking for this thing. So this was the first study which showed a 5-year immunotherapy survival in lung cancer. We did have in melanoma, but it was the first in the lung cancer which is showing that. Now that was 5 years in the first line. Now let's look at the second line. So this is the KEYNOTE-010 in the patients who have who received pembrolizumab versus docetaxel in previously treated PD-L1 positive advanced non-small cell lung cancer patients. So again, here the pembrolizumab was given as a 10 mg per kg every 3 weekly, and there was another schedule of 2 mg per kg every 3 weekly, and chemotherapy in second line was docetaxel 75 mg, and such patients again were crossed over to pembrolizumab arm. Baseline characteristics were quite common, and you can see the 5-year survival rate. The patients who had more than 50% was close to normal, close to equivalent what it was in first line. In first line, it was 31.9%. Here it is 25%. Patients who had a TPS score of more than 50%, while the patients who had more than 1%, the 5-year survival rate was almost 15.6% versus the chemotherapy arm. But these patients have also received the immunotherapy in crossover, so they also survived almost only 6% of the patients. And progression-free survival, you can see even that also is much better, is almost 5.3 months versus 4.3 months, though the median OS is there. But you can see at the end of the 5 years, almost 18% of the patients have remained progression-free in the patients who have more than 50%, while it was 9% when it was more than 1%. So this also confirmed that even in second line, giving an immunotherapy with a PD-L1 score, with the TPS score of more than 50% or more than 1%, you can get an objective responses, time to response, and median duration of response significantly, and you can still achieve a 5-year overall survival rate for such patients. So again, we all know that the treatment-related adverse events are quite common in the immunotherapy arm, and there were discontinuation in almost 6% because of the immunotherapy-related side effects, and deaths were 0.7% only were seen into the immunotherapy arm. So this is again a landmark trial that pembrolizumab monotherapy in patients who have been previously pre-treated with some chemotherapy had a meaningful improvement in OS as well as PFS as compared to the patients who received only chemotherapy and later on they crossed over to the immunotherapy system. You have 5-year overall survival rate almost 25%, and 15% for patients, 25% for the patients who have more than 50%, while 15% for the patients who have more than TPS score of 1%. Again, here also the patient who completed more than 2 years of the immunotherapy, pembrolizumab therapy experienced the durable responses. So second course of pembrolizumab also provides a meaningful disease control. So one should always try to see that they incorporate immunotherapy into the management of the lung cancer, obviously provided they afford the treatment. One has to be very careful about the side effects profile of the patients who are receiving the pembrolizumab, and there could be some long-term side effects. Also, one has to be very careful. So, pembrolizumab monotherapy is a standard of care for the patients who are immunotherapy naive, as well as patients who have been previously pre-treated and those who have a PD-L1 expression. So let me go to the second topic. Can you see my slides?
Yes.
So this is also an important, and I have another 10 minutes to go. Then we can have a 5-minute discussion if somebody wants to ask some questions. That how to manage the adverse events related to immune checkpoint inhibitors. So identification and the management. So what are the immune-related adverse events? We are all aware of the cytotoxic chemotherapy causing the adverse events in the form of nausea, vomiting, neutropenia, and that all related to the prevention in the cell growth and division. We also use targeted therapies like cetuximab or trastuzumab, and they also have some side effects, and that is again because of the blockade of the target molecules. And immune checkpoint inhibitors or checkpoint inhibitor therapies also, they block the immune inhibitory mechanisms, and thereby there is a reactivation of anti-tumor immunity, and that's where they cause the side effects. Though the number is less, they are lower, but there could be a potentially serious adverse events if one is not aware of that. So what is the mechanism of action? We all know that they block the immune checkpoint pathways by inhibition of the immune system, and that thereby reactivates the anti-cancer immune response. And this activation also reduces the cell tolerance outside the tumor, outside that, and that causes the adverse events. And if you see the presentation over here, that compared to PD-1 or PD-L1 block and monoclonal antibodies and CTLA4 monoclonal antibody monotherapy, the adverse events are more with the CTLA4 as compared to PD-1 and PD-L1 targeting agents. And these adverse events are more common into the lungs, like what we can say in the lungs is pneumonitis. In the liver, what we call as an hepatitis. In endocrine system, there could be hyper or hypothyroidism, there could be thyroiditis, there could be diabetes mellitus, hypophysitis. In the skin, you can have the rash. Very rarely you can have Steven-Johnson syndrome. We also know that the creatinine goes up, that is nephritis. Loose motions can be a part of the side effect of the immune checkpoint blockade, and that is related to colitis. And there could be other, there was a patient who said that, yeah, I read the side effects that you take any organ and put an itis behind it. So like arthritis, uveitis, myositis, vasculitis, pancreatitis. So everything is possible, but in a smaller proportion of the patients. So which are the patients where we have to be very careful, or sometimes we may avoid giving immune therapy? Patients like who are having an autoimmune disease personally, or there is a strong family history, one has to be very careful. If somebody has received some immunotherapy in the earlier and has a very serious adverse events, in such patients one should avoid. Certain infections like hepatitis or HIV, where we have to be very careful with that. And patients who are receiving some chronic medications like immunosuppressive therapies, anticonvulsants, and other things, where these are the risk factors where there could be adverse events seriousness. So most important is that one should monitor. Before monitoring, one should know that what are the side effects, as we just mentioned. So whenever the patient comes for the treatment, one has to do the clinical examination. Physical examination should include your skin. You should look for the mucosa. You should also look for do the neurological examination. One should ask for any change in bowel habits, or whether there is any stress and other things. If the patient is having continuous cough or something, one can get the scanning, or one can get an MRI if suppose there is a suspected meningitis. One should also look into the blood counts effectively and metabolic profile. For example, if you want to see the early nephritis, or you have to monitor the creatinine. You also monitor the blood sugar levels if you want to see the pancreatitis or diabetes mellitus. So these are the important factors which we have to monitor from the adverse point of view. You should also get the thyroid function test every 4 to 6 weeks, as well as the baseline, and the patients who are on immunotherapy every 12 weeks. So these are important basic evaluations one has to do. If somebody has got an interstitial lung disease, they can do the pulmonary function test at the baseline. Also look at diffusion capacity of the lung, oxygen saturation at resting, as well as with ambulation or some other things. Baseline ECG and joint examination is also an important, so that you know that there has been change. I had a patient who had an ITP, as well as he had this COPD with the interstitial lung disease, and I had a very tough time in managing the adverse event in this patient. So one has to be very careful with monitoring for such things. So first and foremost, that educate the patient and the relatives about the signs and symptoms. So somebody can have the dry cough, chest pain, diarrhea, black colored stools, nausea, vomiting, weight loss, could be because of the hepatitis. There could be, sweating, that feeling more hungry, thirsty because of the endocrine abnormalities. Output may change, urine output, that could be because of the kidney, and skin related, like skin rash or blisters or sores or mucositis can happen because of the involvement of the skin. So one has to be careful and ask all the time the patients about such things. So once we have identified how to manage such patients, so for managing, we always divide the adverse events into the different grades. Grade 1, grade 2 are easily manageable. Grade 3, grade 4 are serious one. One has to be very careful for managing such patients. So if grade 1 is like mild asymptomatic patients, grade 2 are little moderate, and grade 3 are severe or medically significant, and they do require some treatment. Otherwise, that could become a life-threatening, and they also require a hospitalization. So if somebody has got grade 1 toxicity, then immunotherapy should be continued with close monitoring for grade 1 toxicity, except if somebody has got neurological toxicity or hematological toxicity and cardiotoxicity. So one can wait for some time. Once it resolves, then can go ahead, and there is no need to discontinue immunotherapy for grade 1 toxicity. For grade 2 toxicities, you can resume once the signs, symptoms, or laboratory abnormality comes back to the normal. And if required, you can use short-term steroids in the form of prednisolone, 0.5 to 1 milligram per kg. And depending on the requirement, then you can restart the immunotherapy for such patients and can be restarted. But the patients who have a grade 3, they usually require hospitalization. So we give what we call as a high-dose corticosteroids for such patients, or prednisolone, and it should be continued for a while. That means slowly tapering off over 4 to 6 weeks. And if the symptoms do not improve, then one can use infliximab or some other drugs. But if all the symptoms they settle down, one can offer, but you have to be very cautious if by again re-challenging the immunotherapy. But the patients who have grade 4 toxicity, one should discontinue permanently the immunotherapy for such patients, except for the what we call an endocrinopathies, which can be controlled with the hormone replacement therapies. So let's look at what is been experience of pembrolizumab and side effect profile in India. So it has been given to a lot of patients of the melanoma as well as in the lung cancer. These are the two approved indications, and now head and neck is also, I think, coming in. So it has been given to almost 2,800 patients in both the indications like melanoma as well as non-small cell lung cancer. The median duration of treatment given was 4.2 months, and there are 600 patients who received more than 1 year of the immunotherapy, and probably these are the group of patients who will do very well. Pembrolizumab discontinuation was somewhere around seen in 5% because of an adverse event, and serious adverse events were reported in almost 10% of the patients receiving the pembrolizumab. What were the more common in India, like pneumonitis, colitis, diarrhea, and pyrexia were common. And also the hyper and hypothyroidism, both were also seen in the patients. And very few patients were seen in the grade 3 and grade 4. Majority were at grade 1 and grade 2 for such patients. There were some infusion-related toxicities also, but they were reported in a very small number of patients, actually 6 patients in out of 2,800. And even in the larger data of KEYNOTE-001 and 002, the infusion related reactions are much lower as compared to what we see in the rituximab or the cetuximab and other things. So those were also reported. Very few patients had Guillain-Barré syndrome or myocarditis related to the pembrolizumab. When does this time of onset and median duration? Time of onset, if you see, hepatitis happens somewhere around 8 days to 21 months. Pneumonitis happens early, but the median duration seen is also not very long. Only the patients who have hepatitis and hypothyroidism, probably it is little longer, but most of the time it gets resolved in a very short period of time. So the rate of discontinuation was seen more common because of pneumonitis and colitis, very rarely because of the hepatitis and hypo and hyperthyroidism for such patients. So what are the guidelines? I'm not going to go into the much details, but we already discussed that any patient who has grade 1, grade 2, you can re-challenge after discontinuation or stopping for some period of time when the signs symptoms recover back. So grade 3, with caution, you can restart. But the patients who had grade 4 toxicity, one can stop for pembrolizumab or any immunotherapy for an altogether. I don't want to go into the much detail because this is a too busy slide how to manage every individual, and this will be also available in the tracking set what you are going to see. So in summary, I would say that yes, immune-related side effects are common. One has to be aware, and they are all because of the activation of the immune system, and they can attack the normal organs as well as tissues. So everybody, including the doctors, the patients, caregivers, should be aware that loose motions or skin rash could be happening because of the adverse events of, and they should report to the doctor whenever they are going for the treatment for such patients. So, and all these adverse events mostly they revert back on their own or with the treatment with the steroids. Very rarely they require discontinuation of the therapy, and timely management is critical to ensure that the patients do well with the immunotherapy.
बिल्कुल तुम्हारा लेक्चर सर आप पता ही ना हमारा डिस्कशन जो पता ही ना हो थोड़ी और 2 कलाक
5 minutes before if somebody has any question, because I was not aware about the panel discussion, so I said let me just do some time.
Thank you, Dr. Maheboob. It was an excellent talk, and you have summarized nicely the data of the trial involving pembro, KEYNOTE-024, and on behalf of the organizing team HOC Vedant, as the Diwali days are nearer, we hope everyone will be joining me in conveying our greetings in advance for the Deepavali, and we hope that our patients will also benefit with more Deepavali celebrations, more number of Deepavali celebrations with these new advances. You have nicely summarized the common toxicities, their mechanism, what are the risk factors, when to be careful and avoid these immune check inhibitors, particularly which subset of patients and which drugs patients are taking, they have to be avoided on immunosuppressives, antiarrhythmic, with patients how to have baseline monitoring, continued monitoring, when to hold, when to continue, and when to recontinue or have permanent discontinuation. So it was a practical guidelines to every one of us. Thank you very much, and please stay with us for the as a panelist in the final session.